Like I made my living for years doing real life exposure therapy for people with fears of snakes and dogs and cats and driving and fears of the sight of blood and things like that. Were they distress during treatment? Yeah, but part of the skill of a psychotherapist is titrating the amount of exposure so it's never overwhelming. And literally within an hour, you could produce demonstrable effects with people who initially were cringing in fear 20 feet away from a snake. At the end of 1 hour, they could be holding a snake and not stoically enduring anxiety. They could actually become holding a snake with 1 hour of well conducted exposure therapy.
1 hour?
1 hour. Now, you bring
Wow.
them back in a week, they might regress a little bit, but you do it again and you increase the contact. You use a bigger snake in the 4th or 5th session or something like that. You use 2 dogs instead of 1. Use a bigger dog over time, very gradually working up, always with client consent, always with the full knowledge. They know they can stop at any time. You can say, "Bruce, I need a break," or, "Bruce, I wanna stop." So I would say exposure therapy is something that could easily overwhelm a patient if conducted in the hands of an incompetent therapist. But done by somebody who knows what they're doing and is familiar with the learning theory foundations of it, it's usually going to go really, really well. And real life exposure therapy for specific phobias and social phobias and OCD and agoraphobia are among the best research supported treatments there are for those conditions.
That's so fascinating because, with the exposure therapy, kind of one of the primary purposes of it is to make the client uncomfortable so that they say, I am uncomfortable, but I'm still okay. I survived this. Okay, maybe that feeling of discomfort is not as potent or overwhelming as I thought. And like ERP, these types of treatments are the most evidence-based for these conditions. The kind of common wisdom in psychotherapy is your goal is to make the client comfortable and to soothe them. And those type of therapies are far less evidence-based. How do you explain that disconnect?
I don't know what you mean by you say they're far less evidence based.
So I'm thinking of therapy that's rooted in like validating all the client's feelings. The client's always right. Affirm everything the client says. I call it the customer's always right model, where it's like my goal is to just like soothe the client and tell them that they're right about things. I feel like that's a common mentality among therapists, which is very different from the ERP model.
Yeah, that's very harmful and destructive for clients. Clients don't want to be soothed. They don't want to have their feelings validated. They want to get rid of the discomforting feelings. They want to overcome their fear of birds, for example, that prevents them from walking outside. So when you do exposure, just to roll with that, what you see is initially, you typically see a decline in behavioral avoidance. Then you'll see a decline in self-reported feelings of fear, like on a scale of 0 to 10. Every few minutes, you're asking them, "How you doing? How you doing?" And then the last thing to dissipate is physiological arousal, like high heart rate or sweating. And treatment isn't concluded, not when you're able to hold a snake or touch a dog or something like that. It's when they can do that, their heart rate's not racing, and they're feeling comfortable. That's when you've succeeded. But the idea you're going to sit in the office and validate their feelings, "Oh, yeah, a lot of people have a fear of snakes. It's perfectly understandable." That's not going to help them overcome their fear of snakes.